Do either of you have any opinion or feedback on dynamic neural retraining system?
I don't really know that much about it. I think that, the idea is, or in general, when you have a condition where brain cells die off, I sort of describe the brain as like a highway system. So the best pathway, the fastest pathway to get the information out is the interstate. But when you have something like MSA or Parkinson's disease, the major pathway is blocked off. So you have to use the back roads to get where you want to go. You can get from here to New York City by the interstate fast, and you can get by the back roads. But the more you use those back roads, the more you know where to go, and it doesn't take you as long. So I would assume that that's what that is trying to do, is to reinforce other patterns of movement to get you to use those back road pathways and make them stronger so that when the signal has to go, it goes that way, but still can go that way more efficiently.
Do either of you have any experience or opinion about the use of cannabis?
I personally do not. So I don't prescribe it because as a sleep doctor, 90% of what I prescribe is controlled, so I don't need another reason for the DEA to come looking at me.
Mm-hmm.
But I don't personally have any objection if the person wants to pursue it. From a sleep standpoint, cannabis has two effects. So the initial effect is it does help with sleep latency. It helps people to fall asleep faster. That effect often attenuates. So that's very prone to tolerance to develop. So often that's why it's not a great sleep aid, is that often the sleep initiation effect really doesn't last very long. And the other effect it can have is REM suppressant. So, and kind of the subject came up during the break of kind of off-label uses of REM suppressant medications, REM sleep suppressant medications to control REM behavior disorder, because if you're having less REM sleep, if you're having less dreaming, well, you're going to have less dream enactment. And so cannabis can theoretically help in that degree just by suppressing REM sleep. That's often people who habitually use marijuana. Often when they stop, they have a huge amount of rebound dreaming, vivid dreaming, lucid dreaming. And it's just the rebound from all that REM suppressant, like a starving person at a buffet. The brain's just grabbing as much as it can. So anyway, from my standpoint, no particular objections. I don't prescribe it. It's got its own issues, but.
Mm-hmm. Anything to add?
No, I don't prescribe it. You need a special license to be able to prescribe it. So just because your doctor thinks it might be a good idea doesn't mean they can actually write you a prescription for it. But I have patients with different disorders that have gotten it for different things. Usually they have the easiest time getting it for PTSD. That post-traumatic stress disorder as a diagnosis, and then they have Parkinson's or Huntington's. I've had people send me videotapes of their walking before and after using it. There's no difference that I have seen, but it doesn't. If you don't have much to try, there's no reason not to try.
I guess it's a question and a statement that not my family member with MSA. This isn't specific to him, but we had another family member that had an illness, and we went to all kinds of doctors and university hospitals, and they did not consider a root cause that was the problem. And so I just want to suggest that environmental factors can really have strong implications on the neurological system. And all of the sleep hygiene, I mean, we were told to do this crazy jumping through hoops for sleep hygiene when the fact was that our home had toxic mold. And you can do all you want for sleep hygiene, and you can take as many drugs as you want. And if you don't fix the problem, none of those can help. But I do think that mainstream medicine is not even clued into that. Just my personal experience.
Okay, Dr. Colcher, we have a question for you. Specifically, is it LRRCA? And where does one get genetic testing?
That genetic testing may be done only in specific laboratories. It would not be covered under insurance, and that you may have to contact the person at the research laboratory to be able to get genetic testing for that. A lot of the there are a lot of genes that can be checked for different disorders, and I don't know how much good it does you to actually know your gene status, because it doesn't change the treatment in any way.
Connections between autoimmune and MSA.
And there are a lot of autoimmune conditions that can sort of mimic symptoms of MSA. Let's take like fibromyalgia, where patients feel tired all the time, they feel weak, they feel stiff, they have trouble with their balance, they may have trouble with their speaking, so that can be confused. We usually probably the first doctor that sees you will sometimes send some blood tests to make sure that you don't have an autoimmune condition, to make sure you don't have thyroid disease, something that could be confused with the symptoms of MSA. There are theories that there may be some inflammatory processes going on in the brain, whether those are actually autoimmune or just too much inflammation. We don't know. So, but typically, even though the diseases like lupus or autoimmune thyroid disease can coexist in a patient with MSA, it isn't necessarily the causative thing.
I have another question. CPAP versus, is it BiPAP? A patient uses a CPAP now in an advanced stage of MSA and does not want to trach. Is switching to a BiPAP recommended?
Sure. So the difference between a CPAP and a BiPAP, both of them are PAP, positive airway pressure. It's pressurized air. CPAP, the C stands for continuous, so it's always the same pressure going in, whether the person's inhaling or exhaling. A BiPAP, it stands for bilevel. There's a higher pressure on inhalation, and it drops the pressure down when it senses the person trying to exhale. If you go to slightly more complex kind of BiPAP machines, now they also can tell if the person's not even trying to breathe, and if the person doesn't breathe for long enough, it'll actually kick in and breathe for you. The main advantage that BiPAP has over CPAP, there are really two. The first is that often that difference between the inhalation and the exhalation pressure is more comfortable, because sometimes one of the things that bothers people about PAP is feeling that you're having to work harder to exhale against this air coming in. And so by dropping the pressure down when you exhale, it can often be much more comfortable to use. The other difference, though, is that that pressure gradient helps the lungs to inflate and deflate. And what that does is it can help oxygenate the person, help blow off carbon dioxide, because when you're not breathing as well, the problem isn't only not getting as much oxygen, it's building up of carbon dioxide as well. So the BiPAP, instead of just holding the airway open like a regular CPAP does, can help ventilate the person as well. The real indications for when you know someone needs to go from CPAP to BiPAP, usually just because common things are common, BiPAP's much more commonly used in that manner for COPD, emphysema, that kind of thing. Some neuromuscular diseases can require BiPAP. MSA can at times require BiPAP. The big question really is, you require either a sleep study and or a blood test next morning to really see if someone requires it, because what you really look to see on a sleep study is, does a regular CPAP maintain their oxygen levels okay? And sometimes you can get a rough idea of carbon dioxide levels. And if it doesn't, then both it's warranted and insurance will cover a BiPAP, and you switch to BiPAP and you see if BiPAP is superior. And sometimes it is. The other thing that you watch out for, best with the blood test the next morning, but sometimes you can get an idea on the overnight, is if someone's carbon dioxide levels build up at night, then the BiPAP can be superior, because that can help get rid of those higher levels. So a long-winded answer, but the short answer is it may be necessary. Just kind of advancing MSA doesn't in and of itself require BiPAP. Strider doesn't always respond to CPAP, and there are reasons why that can happen. And if it doesn't, BiPAP wouldn't get over that problem. So it may or may not be necessary. Now, the follow-up, the other question that I was asked was, if someone is uninterested in a tracheostomy for many reasons, and tracheostomy, while it's remember that's the hole that the person breathes through, and it works well because all of the obstruction, all of the issues are from here up. So if you're breathing through here, it bypasses the whole problem. So it works, it's effective, and it's really a very minor procedure to do. The drawbacks, the person does have to take care of it. There is secretions can build up. There is always a risk of infection if the person doesn't take care of it. And sometimes it can affect their ability to speak. And often during the day, what people will do, especially if they don't have stridor during the day, is they'll keep it plugged during the day. And that way you can speak much more intelligibly. It's very difficult to speak with the stoma, with the hole open. But if it's plugged during the day, you can speak. It's not an issue. There are other procedures out there. Generally, they're not used very much in MSA because they're just not well studied. It's in such a small patient population, it's very difficult to do any kind of controlled studies when there's something of a gold standard out there. So you're really left with people who say, listen, just tracheostomy is not for me, but they absolutely require something. And those, to get a really kind of full answer to the pros and cons, you really need to speak to an ENT. But the range of procedures that are out there, there are stimulatory procedures that can be done, stimulators that can be placed. There are surgeries where the ENT will go and suture and somewhat pull open portions of the vocal folds to help keep things open, and that can be somewhat speech preserving. Sometimes Botox can be used for vocal cord paralysis, although with this type of condition, often very understandably and appropriately, the docs who do the Botox are very leery about doing so because you don't want to risk spread of the paralysis, because that's what Botox does. It's a muscle paralyzer. You don't want to risk it spreading elsewhere in the airway and making the problem worse. So there are other options out there. They're not well studied. They're not used that frequently, but there are other options out there. So talk it over, and if you, similar to any other kind of any other medical problem such as the MSA, if you're seeing a physician who you're just not comfortable with the answers you're getting, say it's a general community ENT and you feel like maybe they don't have that much experience and the only option they know is tracheostomy, maybe getting a second opinion at a larger center from a different ENT might be an option. Long-winded answer, sorry.
I have another question. Low blood pressure with fatigue. Did I get it right? I'm not sure whose question that is, but yes?
Yeah.
Okay. So what is the correlation with low blood pressure with fatigue? That's one question.
Definitely orthostatic hypotension can cause a lot of symptoms that you don't necessarily think of as related to your blood pressure. Some people get neck pain. Some people just feel tired all the time. Some people feel dizzy. Some people are depressed. Some people feel confused or like they're not thinking as clearly. So there are a myriad of symptoms that go along with low blood pressure, and treating it is important to maximize the blood flow to your brain and allow you to function as well as possible during the day.
How do you feel about CoQ10?
CoQ10 can't hurt you. It is a naturally occurring substance. It helps your cells make energy. I think different specialists use it for different things. So the dermatologists put it on your skin to make it look more youthful. The cardiologists use it for heart disease. It has been studied in other neurodegenerative diseases like Parkinson's and Huntington's disease and Lou Gehrig's disease, and not been shown to have any effect on slowing down the progression of the disease. So I would say it can't hurt you to take it. Depending on how much you take, it can be expensive. Until you have, my feeling is I would rather have you spend your money on something fun than a supplement that you don't really have proof that it works.
What do we know about stem cell research? What is being done in that area?
There is not a lot of stem cell research being done for MSA at this point. I think that the problem with stem cells is that we need to find a source of stem cells that sort sort of like a catalog shopping, that you could order them from some big place where they had a lot of them, and they could send them to you so that you could use them for any disease, and you could play with them and modify them the way you want to. And we don't have that kind of thing yet. So stem cells are are in short supply. Some of the human stem cells that we have at our disposal are, I'm going to say, they're old. So it may be harder to get them to grow because they have been sitting there too long. So I think that it is something that everybody's interested in, trying to regrow new cells and new connections. But your brain is a hard thing. It grows things, and it stops their growth at a certain point. So I'm going to use the Parkinson's as an example here. There was a big study done, I guess, in the 80s, or 80s and 90s, with Parkinson's disease. They used embryonic stem cells. They implanted them in the brains of people with Parkinson's disease, and they found that they grew and they sprouted connections, and the people seemed to get better that had the stem cell implants. But then they got too much movement. Those cells kept growing and kept making dopamine and made the patients actually worse, so that somebody had to go in and then destroy some of the cells that they put in there, because the patients were all like Michael J. Fox and disabled because of that, rather than their Parkinson's. So the stem cells need some kind of regulation when you put them in, so that they don't overgrow or undergrow or overgrow in some place that you didn't anticipate that they would. So I think it's coming, but it's coming slowly.
What is the best solution to keep hydrated in patients that are severely affected by constipation and swallowing issues?
If you can eat, more liquidy foods, things like fruit, things like pureed foods, put thickener if you're having trouble swallowing thin liquids, put thickener in the thin liquids so you can still get the thin liquids down. Having something next to you at all times so that you can just remember to take a drink because it's sitting right there. It's hard if you're busy during the day, but trying to stay hydrated is a challenge that all of us face, and trying to trying to also decrease the amount of foods that will make you constipated. Use more fiber-filled foods, so that you're not so constipated as well.
Okay, can you talk a little bit more about the condition with this disease that impacts the ability to eat and retention for nutrients? We have a patient who's lost 30 pounds in a month due to the inability to retain what he eats, and how this fits into MSA overall.
Swallowing can be a problem. Chewing can be a problem. Just propelling the food into the back of the throat can be a problem. So probably like the first step would be to see a speech therapist, have a swallowing study done, look at what actually is going on when you attempt to eat, see if some just basic modifications of what you do with your head, whether you tuck your chin or you turn to the side, would be more beneficial to get things down. I am a big advocate for grazing, rather than trying to eat, here's a huge breakfast, eat it all, please. Eat a little bit, and then 2 hours later, eat a little bit of something else. So you're snacking all day long. Make your snacks higher calorie snacks. Put some protein powder in the drinks that you drink, if it's a smoothie or something like that, so that it increases the calories. Don't worry so much about the nutritional content if your weight is really plummeting. You want to snack on high calorie foods that you can easily get down, and then you may have to work with a nutritionist or a dietitian to tell you exactly how many calories you should be consuming during the day.
For instance, my husband,
Right.
by 6 o'clock, he's so tired with, he's eating from, let's say, 10:30 to 6:30 or whatever it is, every little while, that even with the break that he gets, like I say, okay, don't eat anything from 6 o'clock to maybe 8 o'clock, nothing, and then I'll give you dinner. He's just so fatigued.
Right.
And then with all that mucus and everything, that because he can't swallow, it all comes back out the other way. So it's just
From a
what is-
fatigue standpoint, I wouldn't necessarily limit the caloric intake because obviously, forgetting anything else, you need the calories, you need the vitamins, you need the energy. So I wouldn't necessarily limit the intake purely based on fatigue. I would address things more from a determining why the fatigue is there. Is it, say, one of these coexisting MSA, narcolepsy, say some other disorder, and treat the underlying issue from a fatigue standpoint as best able, rather than limiting the diet based on that.
And if chewing is an issue, there's no reason that you can't get your calories in liquids, in smoothies or something that would be easier to swallow, so you don't have to really work on clearing it so much from your mouth and chomping down on it. So changing the consistency of the food so it's easier to go down. And again, a speech pathologist might be helpful in trying to determine which consistency foods are easier to get down.
Okay, next question. What causes a person with MSA to react to situations? Laughing when something's sad, crying when something's funny. We've all seen the Danny Glover commercials.
Yes.
I'm not even going to try to say it because I'll butcher it.
It's called pseudobulbar affect. It comes from degeneration or loss of cells in certain parts of the brain that people start to laugh spontaneously, cry spontaneously. It doesn't have anything to do with how they're feeling, and it doesn't sound like normal laughing or crying, but it can be very disconcerting if you're sitting in the middle of, a family dinner and all of a sudden you burst into tears or you start laughing like it's a maniacal laugh. Sometimes it's not just a happy laugh. So it can be kind of scary. There are medicines out there to try and treat those symptoms. Sometimes the selective serotonin reuptake inhibitors work. There is the drug Nudexta, which is also available to try and treat those symptoms as well. There is nothing you can actually do to stop it. So medication is probably the best thing.
Cerebellar deterioration. Is it possible that other parts of the brain could be trained to offset the symptoms?
Yes. I think that's why exercise is so important. That's why speech therapy is so important, to try and get you to use alternate pathways rather than the ones that your brain wants to use. Unfortunately, even in MSA with the cerebellar type, it is not just the cerebellum that is a problem, because you can function very well without your cerebellum. If you have a big bleed in your cerebellum and the surgeons go in and they take it out, you bounce back and you can still walk and you can still talk. It takes a while, but it is possible to recover from the loss of a big chunk of your cerebellum. But this is more degeneration in other pathways. So trying to, again, retrain your brain to use those other pathways to the best that you can is the best way to combat that.
Okay, a couple of other sleep questions. I think one of them we kind of covered. How do you feel about medical marijuana for insomnia? So I think we touched on that. Another sleep disorder question is active body movements, yelling, out of bed actions.
What was that last word?
Yelling, out of bed actions or activities.
Sure. So in the setting of MSA, that's almost certainly RBD, the REM behavior disorder that we talked about, and it's dangerous. It's not benign and should be treated, and often is treatable. Is the 5-second synopsis there? But one thing I would also say is that often the treatments are a little bit dose limiting. So, for instance, the clonazepam, the benzodiazepines, if someone is one of the 40% of the population that doesn't respond to melatonin, the side effects can sometimes dose limit things, at which point you're really out of FDA approved options. In fact, technically, I don't even believe that clonazepam is FDA approved for it. But there are other strategies that can be taken, things like those REM suppressant medications. So do something about it. And if at the very least, bedroom safety. In fact, if you look in any medical textbook about this, the single first thing that you ever should do is just make sure the bedroom environment is safe and the bed partner is safe.
Yeah, we actually had to install precautions on our mother's bed because she did exhibit this particular symptom. Here's a hard one. What happens when you are diagnosed with MSA but don't fit the textbook pattern of MSA or aren't dying fast enough to be MSA?
There are a lot of people that don't meet the textbook definition of how long you're supposed to survive with a certain disease. So that is why I never tell people how long they're supposed to survive with a certain disease, because everybody's different and it depends. Survival depends so much on your approach to life, on your belief system. People who keep fighting, people who have faith, people who do more exercise, do more to keep themselves active and fit, do better than people who just say, oh, I have this disease, there's no treatment, let me just sit here. And they go downhill much, much faster. The same way I tell my patients who retire, if you don't have something to do with your life, you're going to just go downhill faster. So you need to keep yourself mentally active and physically active. And I have a lot of patients in my practice that have survived more than the whatever they say in the textbooks, like 7 years. That is not a reasonable number, because we advocate a lot of healthy behaviors for people, and people live longer and are able to have a better quality of life for a longer period of time if you adapt those kinds of behaviors. So I would, if you have symptoms, autonomic failure, Parkinsonism, cerebellar disease, it is pretty likely that is, and you've been tried on, say, Parkinson's medicines, and they don't have a dramatic effect on you if you have the Parkinson's kind, then the diagnosis is not necessarily in question just because your survival is long.
It's a good segue to the next question, which is just some general tips, what's recommended to deal with how to live, how to manage with an advanced MSA diagnosis, and what is the general life expectancy?
Symptom management. So from a how do you live, how do you deal, how do you go forward, it's really, from a medical standpoint, is managing the symptoms, the urinary symptoms, the autonomic symptoms, the gait symptoms, keeping safe, keeping everything, allowing yourself from a symptomatic standpoint to live as normal of a life as possible. From a life standpoint, I'll defer to Dr. Colcher, but generally it's staying positive, enjoying the life that you have, and not allowing yourself to dwell on the condition, as easy as it can be for me to say.
It becomes harder when you're no longer able to walk and you're in a wheelchair, or you can't move the way you want to. That is not, sounds terrible, this is not an excuse not to exercise. So still range of motion, trying to keep yourself flexible, trying to keep yourself as strong as possible with exercises that you can do in a chair or in the bed is something to still keep working on. Paying attention to mood issues, because if people get depressed, that also makes them go downhill faster. So you want to treat mood issues when they come up. If they're really anxious, you may need an anti-anxiety medicine. If they're really depressed, you may need an antidepressant to keep their spirits up, keep the people socially engaged, so that they're not, stuck in the house with nobody to see. Try and make sure, if you can get into a wheelchair, that you can get outside, that you get some fresh air, that you get some sunshine, that you really are able to enjoy what you can enjoy. Having people come to the house, visiting nurses. I have used hospice. I had one guy that I had with MSA who was on hospice for like 2 years. Then he wanted to go to England to visit his family, so they stopped the hospice. He went on vacation, and he was in a wheelchair. He could not communicate verbally to me, and but still, that's what happens when you stay engaged, is that you can live for a long period of time. So don't, and still enjoy things. So don't feel, if the doctor recommends hospice or something like that, it doesn't mean that you're going to die soon. It means that they have a lot of suggestions for comfort and mental health issues to help both you, the patient, and the family members to prepare for the later stages of the disease, and to get yourself comfortable with the situation that you have there. And I keep getting patients thrown out. So everything I said about nutrition, if you listen to it and you actually gain weight, then they'll throw you out of hospice, because they only like people who keep losing weight.
Are there any
Yes.
other? Oh, perfect.
I want to back up what the doctor said about a water therapy. My wife uses a walker. She can't walk without it, but in the water she can walk freely.
Mm-hmm.
And so anyone who has an opportunity, join a local Y, the club or whatever, and see if you can get in the water. Even if you're in a wheelchair, that may really help stimulate your muscles. Mm-hmm. The second thing is, if you go and you can go on Amazon and buy the videos to watch at home on chair yoga and chair therapy. You can really do a lot even though you're sitting down. Okay. So those are two recommendations I would make to follow up.
There's a lot of exercises that you can do, even cardiovascular, that you don't need to be standing. I just got myself a personal trainer, like it's about time. But he has me doing this thing with my arms. There's a little thing that you can buy that you can put it on a table, you can put it on the floor, so you can pedal, and it doesn't require any climbing onto a bicycle, and it still gets your heart rate up so that you have some aerobic activity and exercise. And that exercise also can help your sleep, can help your mood, can help a lot of things. So look for things that can be adapted so that you can still use them no matter what position you have to be in.
Just as an FYI, we have NJ Care and Palliative Care here today with a table outside, and we have some reps here. So if you have any questions as a follow-up to this, feel free. Okay. Yep, hands up. If you have a question, I will come around with the microphone.
Yeah, any suggestions on how to deal with severe gastroparesis and nutrition in conjunction with MSA?
I have a lot of patients that have been coming to me that are on this new drug called Linzess. I don't know. But a lot of people that were hospitalized with like impactions and chronic like bowel immobility. There are some, if you see a gastroenterologist, sometimes Botox again can be used on the sphincters of the stomach to try and help it open and help it empty. So I would, if you see a gastroenterologist, there may be medicines that can be tried. Trying to eat smaller quantities of stuff so that it can go through, more liquidy stuff that can go through may be helpful.
Okay. Oh, another question?
Is there any cures in the future for this?
I hope so. I think we all hope so. They are looking at the study drugs are in development that actually look at alpha-synuclein or work on alpha-synuclein, which is a protein that is a problem in MSA. So that kind of therapy has the potential to stop the progression or to potentially cure the disease. But it is still really in its infancy, and we don't know if it will work for sure.
I just wanted to follow up on that question. I have a son with an issue, but there's always hope that he'll be cured. But with MSA, there's not much hope. and I was wondering is there a record of anybody who's gone into remission or being cured, basically?
Has there been any record of any remission or?
It is a progressive disease. For some people, it can progress really slowly so that they seem to plateau at one level for many, many years and not get worse. But eventually it does progress.
Could you address the age of onset of the disease if someone is diagnosed earlier in their, say, in their 40s? Is their progression more rapid and their life expectancy any different from someone who's diagnosed at an older age?
Not so much. Not like in Parkinson's disease, where the younger onset sort of makes you more sensitive to the side effects of medicine and seems to make symptoms come a little bit faster. In MSA, the age of onset is usually in the 50s, anywhere to the 70s, and progression does not depend on how old you are when you get it.
Good afternoon. Mine is a nutrition question. And have you heard of cinnamon, Cylon, and vitamin B in terms of our nutritional value?
Cinnamon is very good for you. Again, it works to help to dilate blood vessels. So adding cinnamon to your food, you can put it in your coffee. You can use it in a lot of different ways, and it smells wonderful. So, and B vitamins also are something to make sure that your levels of B vitamins are actually where they need to be. B12 deficiency, for example, can cause problems with your balance, problems with your walking, problems with your thinking. Thiamine deficiency can cause problems with your eye movements, and again, problems with your balance and problems with your thinking. So it's important to check those levels and make sure that they're supplemented adequately.
Okay, is agitation or paranoia a normal part of the progression of this disease?
My understanding is, correct me if I'm wrong, but not as part of the general disease process in and of itself. I mean, obviously, people who are going through the process are at a significantly increased risk of mood disorders, but not in and of itself with the condition.
That went away when medication was stopped.
Right.
Sure.
So some of the Parkinson's medicines can cause psychosis and delusions and paranoia. So that would be more a medication side effect rather than a disease effect itself. Definitely agitation can increase, especially if you feel like you can't breathe and you can't communicate. So if you have something that you want and you can't say it, then you're gonna get agitated, you're gonna act out, and your behavior is gonna change. So trying to get to the underlying cause of the agitation is helpful. Trying to ask simple, like, yes or no questions. Is this what's bothering you? Is this what's bothering you? Till you can get to the root of the problem.
How do you deal with getting the right therapy, the right treatment when, like, I live in a little tiny podunk town 8 hours from here. I have to travel 3 hours to see a neurologist who's never heard of MSA. I got diagnosed by going to Boston, and then the Mayo Clinic got involved. I have never been there because I can't travel that far. This was a 3-day and 3 days back effort on our part. And I see a neurologist now only once a year because they don't know what to do. All the medications that we tried in the beginning, I either had a reaction to or they made things worse. So right now I'm untreated in any aspect other than, sleeping when I'm too tired and being awake and doing stuff when I can. But I'm not dying fast enough for them, so they think I don't have MSA because you'd be dead.
Mm-hmm.
I've been everywhere from your fat and female to MSA with dysautonomia, well, I can't dispute the dysautonomia because I pass out all the time. But, there's still that part of me that doesn't want to accept the MSA because nobody that knows anything about it has told me I have it. So when people say, "Oh, you have MSA," which is rarely anyone I've ever met because they don't know what it is, I always say, "Yeah, but I'm not dying until like the doctor that looks like Tom Selleck tells me I'm dying," and I haven't had that yet. So I don't know. I tend to take a positive attitude just because I used to be a nurse, and I feel like, well, how do you really find out? And do you have to find out for 100% sure? Because they say you don't know till you die, and they do an autopsy. So do I really need to know? Should I pursue different neurologists or?
It's nice to have somebody who knows what you have, but the truth is that, do you need to follow up with a neurologist every 3 months when your symptoms are changing so slowly? The answer is no. That most of the autonomic symptoms should be able to be managed by your primary care physician, that they know how to treat blood pressure. If you need a urologist to help with the urinary symptoms, they may be able to recommend medicines for you. A GI doctor may be able to help with motility issues or swallowing issues that you're having. So you don't necessarily need a neurologist to handle all those things. And maybe getting yourself to a neurologist maybe once a year would be enough to sort of look at how things are progressing.
That's actually what I'm doing now, but my neurologist that I had at this big teaching facility in Albany, New York, has left, and the one that took over for him doesn't know MSA. So I'm back where I don't know what to do. I don't want to keep switching hospitals because then they tell you that you're doctor shopping.
Right, but if your doctor left and you want a doctor that has expertise in MSA, then you should be able to find one.
That also is easier said than done because when you call a practice and you say, "Do you have experience in MSA?" I have always been told yes.
So if you look on under movement disorder specialists, then you're more likely to find somebody who would know what MSA is rather than just a neurologist.
One option also would be if you could find a movement disorder specialist who was willing to participate in telemedicine visits. So similar to the people who are remoting in, we do it. I know that it's becoming something of the wave of the future where you would actually, through an app on your phone, on your computer, you would actually interact, do the visit that way if getting out and traveling is enough of a problem.
And if you do come across a physician that would be interested, please send them to MSA&J. We're certainly happy to help educate and build a spot here for them to learn more about the disease. We have plenty of resources. We have a great medical board that can assist as well. And bonus points if he looks like Tom Selleck.
I just have a couple comments. And one you touched on already, resources as far as doctors that have expertise and experience with MSA. The MSA New Jersey site has some posted throughout the New York, New Jersey, Pennsylvania area. And then, as she said, we ask that as people find good physicians that they work with in their respective regions to let us know. There's even a form up there that you can upload it so that we stay current in providing that information to try to help you. The other thing that I want to add, just some of the conversations that have come up here in terms of support and things to do and staying positive. There are a couple of things. There's some other therapies, and they're not really covered by insurance, but we try different things with Mom. So some people that have been with the MSA group for a while know I'm sort of a proponent of some of these things, like dance therapy, music therapy, and these sorts of things. Mom's speech became very difficult as the disease progressed, and we brought in a music therapist, and she came to the house. And I'm telling you that Mom had difficulty speaking, but they'd start with old songs that she knew, and she'd start singing. I mean, she would leave, the music therapist would leave, and Mom's spirits were up, and it was a positive experience. So just, my point is, don't be afraid to look at alternatives that might connect to things that you're interested in, and that might have some support that you may not think about. Right? So that's one thing. The other thing I just go back to is really you're here together as family, spouses, kids. That's so important too. We had such a close family unit, and I don't say this to pat us on the back by any stretch of the imagination, but Mom's doctor always used to say, "You guys keep her going." Like, we were so close, we were always there, and we lived life as normal as we could. We went out, right? Wheelchair and all, everything went out. We went on trips, we went day trips, we went out. Keep living. And Dr. Colcher referenced that before. You got to do as much as possible, stay positive, be active with your families, and continue that. That's a really important part of the process of staying positive. And as I said, the doctor commented on that because it was that recognition of that unit, that family unit, the love, the care, the activity. That's all really part of it, you know? So just my 2 cents.
And I'm going to piggyback on that because I think I said to someone earlier that just wake up each day and find one positive thing about that day. And it could be the gratitude that you have a loved one there to care for you. It could just be a beautiful flower you see, a bird flying by, but try to find something positive in each and every day, because each and every day for any of us is a blessing.
I want to reiterate something that the doctor said, and it's about your spirit and about your well-being. And what I found, is my beautiful wife over here, Ronnie, who has helped me realize that as an MSA person, life goes on, and you got to deal with it, and you will either deal with it emotionally badly or emotionally great. And I feel great, and I'm here to tell you that it's your spirit that helps you move along, your faith that helps you move along and move along positively. And that's what I wanted to say to the doctors, that you're very supportive in terms of what to do, but it's how you do it is the way you really get around it all, and that's very serious. When I speak about that, as a MSA cerebellum person, it's important to the doctors and important to me that you find somebody that understands what you're dealing with. That's all I have to say.
Agreed. Power of positivity. You have a great spirit, Lloyd. And, I have often said that if my mother was still here to take part in what we're doing, she would be our MSA cheerleader. She would be rooting for all of you to go out and enjoy your life and live your life while you're still here to do it. Enjoy your family, your friends, your loved ones. While you can dance, dance. While you can sing, sing. While you can eat, eat. And just stay positive and focus on being in the present. So the really good news is that I'm hoping most of you guys can stick around, because at the end of the day, we're hosting a support group, which will give you guys an opportunity to mix and mingle and meet your fellow warriors and share your tips and your resources and your stories and your journeys, and hopefully walk away feeling energized and positive about this.
Did you talk at all about the risk of dehydration and UTI, and how that could manifest itself with some symptoms that you might misunderstand?
MSA is a slowly progressive thing. So if you suddenly get worse, that is not from MSA. That's from something else. And you need to figure out what that is. The most common thing is urinary tract infections. It can make people confused. It can make people more tired. It can make people more off balance. So that is really important to, if something changes abruptly, that you need to go to the doctor or you need to go to the hospital to figure out what that is. Sometimes it could be a stroke. It could be that you fell and you didn't mention it, but you had some bleed, like a subdural hematoma. So it's real, or that you're getting sick. I've seen people go downhill abruptly when they just had a shingles outbreak. So you need to figure out what it is that changed whatever is the additional stressor on your body and treat that, and then you will bounce back. But hydration is key. Hydration is one of the treatments for low blood pressure. So you want to, as we talked about, keep yourself hydrated, keep some liquid near you and actually drink it during the day. But it is very important, the hydration, both for a blood pressure perspective and from a urinary tract perspective.
And the good news there is that, assuming it isn't one of those more ominous things like a heart or like a stroke or a bleed or something along those lines, generally those sudden declines are reversible once the underlying inciting incident is corrected.